Thank you very much. Thanks for the invitation and the kind introduction. So here are my disclosures. And just wanted to start this with talking about pancreatic NETs and liver mets. This is a very common problem. So these are just a few studies I found on the web there. So mets in the liver are seen up to 50–60% of the time. If you look at all comers with PNETs, depending on which registry you look at, if they are not there at the beginning, they will possibly show up and likely show up later. And then the overall survival is actually improving in PNETs, and the overall survival seen at at the single institutions does not reflect what we see in the SEER or NCDB, which probably reflects the delivery of care to those populations. So that's a disconnect that we struggle with. So the prognosis in stage 4 disease is poor. So this is just coming out hopefully in the next few weeks. So this is SEER. So here we're looking at all stages. We can see that since 2009, survival has improved. But if you tease out the stage 4 disease, all comers stage 4, the survival has not improved much in the last 20 years. You can see it's statistically, that's not significant, but you can see that the red line on the right-hand side is a little bit better. So maybe we're making some progress here, but still, by and large, at least according to population-based databases, the survival is poor. So how do we tailor the treatment of PNETs liver metastases? So I think it's very hard to do. It has to be done in the context of a tumor board, ideally, but not everyone needs to be presented at a tumor board, though. So there are potentially resectable lesions. We all have seen this spectrum. There are a few localized resectable. We can use regional therapy. There are diffuse innumerable, although Rod Pommier tells me never to use the word innumerable. Everything can be counted. And unresectable, and that's where we use systemic therapy. And then there is this thing in the middle. How many are many, and what are we going to do with those in the middle? And that's what I was hoping to explain here in the next few minutes. So, is anyone cured with a liver resection? For small bowel NETs, the answer is probably no. But does it really matter if we debulk? It probably does. And if you look at micrometastases in uninvolved liver, and this is a recent paper from Norway, you could see that in all 10 of 10 tested patients, if you looked at uninvolved liver, there were islands of liver metastases, little micrometastases throughout the liver. Whether these ever grow into a clinical problem remains to be seen, but I don't think we ever truly cure anyone of liver metastases. Whether this holds true for pancreatic NETs, we don't really know. Most of the data is from small bowel NETs. So is there then an optimal approach to the management of PNET liver metastases? And I think before we go there, we need to ask ourselves, what are the goals of doing this? So I look at this when with trainees in my clinic, we're controlling symptoms and we're prolonging survival. And oftentimes these two go hand in hand. And regional therapy, as all know here, is extremely effective controlling symptomatic disease in syndromic patients, but systemic therapy is as well, but probably not quite as fast and maybe not quite as good. So what about combining systemic therapy and regional therapy? Well, we all do that in practice. And then the prolongation of survival, and this is where we struggle with the surgical literature. It's very hard to show survival improvement with resection, especially looking at retrospective studies, because there's a lot of bias that goes into who gets surgery and who doesn't. At least we have some data from the prospective trials of systemic therapy, and they'll show you a few of those. So this is a meta-analysis that just got published a few years ago, looking at benefits of hepatic debulking compared to no surgery, systemic chemotherapy, and embolotherapy. And if we look at this here, I just want to highlight that all three categories favor surgery. So then again, there is bias that goes into this, and the meta-analysis doesn't correct for all of those biases. But it appears from this that surgery, even in this meta-analysis, is of benefit. So what about resection in stage 4 disease? More SEER data coming out. So this is coming out hopefully also in the next few weeks. So we looked at the SEER data with pancreatic NETs. We looked at survival in patients with stage 4 disease who had surgery, liver surgery, and or primary tumor surgery. And you can see there's a huge difference here. But there is also a huge difference in these two populations. So in terms of who got surgery, in terms of age, probably performance status, and other things of that nature. And if we do liver surgery, how extensive should it be? 70, 80, 90%? And we debate this back and forth at all tumor meetings. So maybe we'll have the answer today. So systemic therapy. So looks like it went. Hang on a second. There we go. So the available data with systemic therapy doesn't really answer which one is better, resection with or without systemic therapy, but it may clear the picture a little bit. So a lot of the survival data was actually generated before we got our best systemic therapy in the US. We only got PRRT in 2018. And sequential therapy, where you play one card at a time, and be it regional therapy or systemic therapy, may actually yield the best results. And then obviously this has to be a shared decision making. So these are the things I go through my mind when I see someone being considered for liver-directed therapy or liver therapy. So the extent, obviously, of the liver mets, the presence of the functional syndrome, and tumor grade. For higher grade tumors, especially grade 2 above, with Ki67 above 10%, these are not necessarily nice players. So I'd like to observe them on systemic therapy and just see what happens there, see if this all sort of mets out throughout the liver and bones. And then obviously patient preference, comorbidities, and then cost and accessibility. So let's talk a little bit about the drugs. So we have somatostatin analog. So this is from the Clarinet study. This was a randomized phase 3 study comparing Clarinet to placebo in patients with pancreatic and small bowel neuroendocrine tumors. And this is the pancreatic neuroendocrine tumor subset. As you can see there, the PFS was 12 months for placebo and 29.7 months for lanreotide, and there was a crossover built into this, or actually an open label extension. So at the end of the day, there was no difference in survival. So it doesn't really matter, at least for the lower grade tumors. These were all KS7 less than 10%. If you start them on lanreotide early and just, or if you wait until they progress, the overall survival is going to be the same. So what about everolimus and sunitinib? A complex slide, but I just wanted to draw your attention to those boxes there that have the blue rectangle around them. So everolimus, median overall survival in a randomized clinical trial, 44 months. Sunitinib, 38.6 months. So we're actually getting decent results in patients with metastatic disease with systemic therapy alone. So we're waiting for this study to be published, ECOG 2211. This, I'm told, is coming out very soon. So this was a randomized phase 2 study comparing temozolomide with capecitabine and temozolomide, with the primary endpoint being progression-free survival, and the addition of capecitabine to temozolomide almost doubled the PFS. But what remains to be seen there is the OS difference, and the overall response rate here is 33%, which is definitely lower than seen in the retrospective studies, where we've seen numbers up to 70%. Again, just goes to show that when you put an intervention to a rigorous test in a clinical trial, the results are not going to be as good as they are in retrospective studies. So this is a word of caution there. So CAPTEM in retrospective studies, overall response rates up to 70%, but probably mostly around 50 to 60%. Well-differentiated tumors works really well, poorly differentiated not so, but the higher the grade is, the shorter the PFS is in general. So what about PRRT? So obviously all of us are really excited about PRRT. So what do we know about PNET and PRRT? Not a whole lot from prospective randomized studies, essentially nothing, because there hasn't been a single study including those populations. But these are two large retrospective studies from Rotterdam, 600 patients, and if you look at the overall survival for pancreatic NETs, 71 months. On the right-hand side, this data from Germany, from Bad Berka, 44 months. But that was a mixed bag of yttrium-90 and lutetium and a lot of other different things. The one from Rotterdam is very homogeneous, all lutetium-177. So PRRT for pancreatic NETs in general. So we did a systematic review a few years ago, and I'm just going to call out a few things here. So these are retrospective and prospective studies. Overall response rates probably somewhere from 30 to 60%, a huge spread there. PFS ranging from 27 to 42 months. Overall survival ranging from 40 months to 70 months. So as you can see in those retrospective studies, this stuff seems to work. So this is a very well done retrospective registry reported at NANETS last year. So 110 patients treated uniformly with lutetium-177, 4 cycles. RECIST was used, very well done methodologically. Here we can see that the median progression-free survival was 25 months with PRRT. Median overall survival was 41 months. And those who got the chemotherapy before had a much shorter PFS and OS, probably just reflecting that they are later in the course of their disease and just have more aggressive disease. So neoadjuvant PRRT, I wish we had some time to talk about this. This actually might be a thing. And it's very effective, and it can successfully downstage tumors prior to resection. And they just put out 2 studies there, one from India, very well done, looked at PRRT, 84% overall response rate. I'll see how well that holds up, with PFS at 2 years of 90%. On the bottom, there's a study from Rotterdam, just came out a few weeks ago, and looked at sort of neoadjuvant therapy 2, and if you look at those who had PRRT only, 5.5 years, 14.7 years with PRRT plus surgery. That is not shabby at all. So what about the other systemic therapies, PRRT versus targeted therapy? Who should go first? So probably doesn't matter. This just came out a few weeks ago. 500 patients from multiple Italian centers. And here they looked at PRRT up front after somatostatin analog progression versus targeted therapy or chemotherapy. As you can see on the top graph there, the PFS is much, much better with PRRT than targeted therapy, 2.2 years compared to 0.6 years. But at the end of the day, there is no difference in the overall survival. Look at these OS numbers for metastatic disease, 12 years. So this is actually very, very impressive. So the question for me is really, is the whole greater than the sum of the parts? So we take all of these, the PFS from this and the OS from that, and we put it all together. Does that equal sort of just the sum of those parts, or is the benefit actually much greater than that? So that goes to my sort of philosophy of playing one card out at a time. Discuss this in a multidisciplinary setting, go after the liver lesions, and Dr. Zulin will tell us much more about the liver-directed therapy with embolization and ablation. So to conclude, so liver mets extremely common, high-quality studies are still lacking, but we have lots of very, very good quality retrospective data. Overall survival is actually improving for the metastatic disease, but does not at all match what we see in the SEER and NCDB, which makes me worried. Why are those people dying? Are they not getting the care they need? And the combination of systemic therapy and sequential therapy seems to give the best results. And setting back the clock with liver debulking is still something I believe is of value. And then more active systemic therapy is definitely on its way, especially alpha particle therapy and kinase inhibitors. So thanks for the invitation and letting me speak.